prancha, como foi feito anteriormente, se eu diminuir esse tempo, se eu aumentar esse tempo inspiratório demais, eu não posso cair correndo o risco de gerar um volume corrente muito alto, porque esses pacientes normalmente eles não têm problema respiratório do sistema, né, do pulmão, pulmonar. Então, a paciência dele é normal, eu posso estar gerando um volume corrente muito alto. Obrigada.
There's no question that that is a potential, but you have the ability to adjust the pressure. So maybe you're at 15 of pressure support, and as you extended the inspiratory time, maybe you now need to go to 10 of pressure support so that the tidal volume stays within a reasonable range, but the inspiratory time is longer. Clearly, what we should try to do in patients who are breathing spontaneously and triggering the ventilator is try to set the ventilator to accommodate the way the patient wants to breathe. So that takes a little time, and that's one of the things sometimes we don't have. But it takes time standing at the ventilator by trial and error and making adjustments and seeing how the patient responds. And if the patient is capable, asking them if they're more comfortable when you make an adjustment. Particularly the neuromuscular patient who's usually not heavily sedated. They're the kind of patient you can talk to and have the interaction and figure out whether or not your changes really make them feel more comfortable or not. And the goal here is to make them in synchrony with the ventilator, and the more input we get from the patient, usually the easier it is to accomplish that.
Para finalizar, gostaria de que o professor comentasse a respeito se há alguma perspectiva da utilização de monitorização da pressão esofagiana ou monitorização eletromiográfica para possibilitar a detecção automática no futuro, implementada nos ventiladores mecânicos, a detecção automática dos diferentes tipos de assincronia.
I did not get a chance, time was just not available to talk about the panel. But I clearly believe those are the modes of assisted ventilation in the future. Because in those modes, the patient leads the ventilator, not follows the ventilator. Every other mode of ventilation we have, patients are forced to follow the way you set the ventilator. With PAV and NAVA, the ventilator follows what the patient wants to do. And clearly, having an EMG signal from the diaphragm tells you about asynchronies that you don't even know exist. If you've had a chance to use NAVA, you look at patients and think they're perfectly in sync with the ventilator, and then look at the missed breaths and all the prolongation of inspiration on the EMG signal that you simply were not aware of when you were just looking at airway pressure flow waveform, and even looking at the patient. It's really difficult to pick up some of those subtleties that you will see when you look at either an esophageal balloon or a EMG signal from the diaphragm. So I think, in 10 years from now, when we have a EMG signal off of the surface of the diaphragm, put on the chest wall, as opposed to trying to put the catheter in, because I don't know if you've tried to do this in critically ill patients. It's not easy to get a nasogastric tube of that thin caliber that they use for NAVA into patients. We've had difficulty with dealing with the catheter. And I would expect in 10 years we'll have a surface electrode that will go right on the chest wall over the diaphragm that will do everything that the current catheter does. When that happens, we'll all be using those modes of ventilation and manipulations.
Obrigado, gostaria de agradecer mais uma vez ao professor.